Good evening, everyone, and welcome to this very special webcast, Just Diagnosed, What Now? My name is Kirsten Pilati, the very proud CEO of Breast Cancer Network Australia. I want to begin by acknowledging the traditional owners on the land on which we all meet tonight and pay my respects to elders, past, present and emerging. We want to acknowledge the Wurundjeri people from the Kulin Nation where we meet here in Melbourne tonight, and in fact where BCNA is housed in Camberwell. This is a really important time for us to invest in our First Peoples, who we know have far worse outcomes if they are diagnosed with breast cancer. So if you are someone who's been diagnosed with breast cancer and identify as Aboriginal and Torres Strait Islanders, we welcome you tonight and thank you for your attendance. So tonight is going to be an action-packed night. We know that when you are diagnosed with breast cancer, your world turns upside down. Tonight, we want to help you give some level of certainty, but most importantly, some really practical elements that will help you to take back control so that you can feel slightly more empowered at a time that's really difficult for you. I'm really thrilled that tonight we will have Mr. Sunny Giselle and Meg McDonald, as well as Faye Lowy, and I'm going to throw us straight into the speakers because we have so much to get through. So Sunny is, I'm hoping I'm allowed to call you Sunny. Absolutely. I feel like we're friends already, but Sunny has been in practice for over 10 years. He consults in Mitcham and Heidelberg and now also in Surrey Hills. And Sunny has working across both public and private and as well as working at Breast Screen Victoria, a man with so little time in your life. So thank you, Sunny, for joining us here, and I'm going to hand you control.
Thank you, Kirsten. That's very, very kind introduction. So we're talking about when you've just been diagnosed for breast cancer, and obviously it's a very tumultuous time, and I think that having been through this process with hundreds or perhaps thousands of women, or 1,000 or 2 women, it's very apparent to me that women walk in the door having just been diagnosed, and they've lost their equilibrium. And I imagine some of you know what that feels, and there's a real uncertainty. What does this mean? Am I going to be here for Christmas? And it is very, I think Kirsten touched on a point there when she said, to give you back some empowerment in this process, because when you get that breast cancer diagnosis, I think that your world turns upside down, and it's one of the most rewarding aspects of my job is to sit down with you that first time and actually say, hang on, there is a plan, and we can get through this. So I'm going to talk a little bit about how we work out what to do and what that plan is for different women. So the first thing to remember when you get that, if you're unfortunate enough to get that breast cancer diagnosis, is that it is common. It's nothing that you've done wrong. Breast cancer affects 1 in 7 Australian women, 1 in 7, 1 in 8 Australian women. Most women with breast cancer don't have much or any significant family history of breast cancer, and so it just happens. It's just one of those things that happens. A common theme I find at that first consultation is that women sometimes feel like it's their fault for some reason. Oh, I should have been checking my breasts. I should have had the mammogram earlier. And really, it's irrelevant at this point. Most people do check their breasts in some way, shape, or form. Most people have had a mammogram when they could, and sometimes life gets in the way, and you might delay a mammogram 6 months or a year, or during COVID, a lot of people have been unable to access mammograms easily. So the main thing is that if a cancer has been found, it's been found, and now we look forward and say, how do we get rid of this for good? So the first steps when you have received that unhappy news is you need to think about where you want to have your treatment, and to help you with this process, you can have a chat to your GP, and your GP is going to be a great source of information about what sort of services might be accessible to you. Sometimes you might know people who've had breast cancer and might have gone through that treatment, and they can also be a great source of information as well. We're lucky in Australia. We have a great public system and we have a great private system. So you have the option to go either way, and there are great things about both systems. Some women living in the country, they might feel, oh, look, we don't have access to the same services that are available in the city. Most regional centres do have good breast cancer centres. Most services are available in the country as well. And where services aren't available in the country, you can sometimes split your treatment between the country and the city. So, for example, a common complaint of women in the country is that, oh, we might not be able to access breast reconstruction. Breast reconstruction. So sometimes the reconstructive surgery might be done in the city, but you might keep your other treatment close to home. So number one is think about where you want to have your treatment, and your GP will then refer you in that direction. My counsel to you would be try to keep it close to home if you can, because there are a lot of appointments involved. So if you can find a good breast cancer surgeon and service nearby, I think that's a really good option. All right, let's move on. So there's often a degree of panic in this period of the process, and that you've just been told you have breast cancer. Oh my goodness, I need to get this thing taken out yesterday. You actually have time. Breast cancers don't change that fast. So whether or not you start treatment yesterday or whether you start in a few weeks, it really is not going to impact on your prognosis for the vast majority of women. So you have got time to make your decisions carefully and think about that way forward. Right. So your breast cancer surgeon is going to be the primary treating specialist. So your GP will refer you to a breast cancer surgeon or a breast surgery clinic, and that is partly because surgery is often the first step in your treatment pathway. Not always, but often. But secondly, your surgeon, even when surgery is not the first step, your surgeon is going to coordinate that process. So he or she, I should say, is going to organize your treatment plan with you, and that is going to be often and usually and hopefully in the context of a multidisciplinary team. So what I mean by that is lots of other people. So you might think you're just dealing with your surgeon, but in actual fact, from my point of view, I might be discussing your case with the pathologist or a radiologist. I might have my breast cancer nurse I will have my breast cancer nurse involved, and there are a whole range of other doctors, other paramedical staff. There may be geneticists. There could be fertility specialists. There's a lot of people involved, and so we all put our heads together. You may not see all of it, but we all put our heads together and we work out how we are going to treat you to give you the very best outcomes, not only in giving you the best chance of getting rid of the cancer for good, but also giving you the best outcomes in terms of quality of life, because we want you to be rid of this thing and we want you to live well going forward. So something which came up in our discussion for this talk was second opinions. Now, second opinions are a tricky area because I think the idea of getting a second opinion just for the sake of getting a second opinion, oh, gee, this is a serious thing, I better go and get multiple opinions. It sounds okay, but in actual fact, it can sometimes be confusing. So if I tell you one thing and another surgeon tells you another thing, it can be difficult to pick out, well, what do I do here? So at the end of the day, I think it is very difficult for you to be across all of the detail in a cancer treatment plan. So I think at some point there has to be some level of trust. So if you trust your surgeon, ask questions and inform yourself with as much knowledge as you can. If you trust your surgeon, I don't think there is necessarily a reason for a second opinion. If, however, you're just not quite sure and you feel like, oh, maybe there are some other options here. Maybe a surgeon said, we could perform a breast conserving operation, for example, but I favor a mastectomy. That's the sort of situation where maybe you do seek a second opinion to see what a different surgeon might say and weigh up the pros and cons of different approaches. So I don't think it should be a default position that let's go and get a second opinion because this is a serious problem. But I think there is a place for a second opinion. Just be careful about that because it can sometimes get more confusing. I think the bottom line is you want to find someone reputable, someone that you feel comfortable with, someone that you trust, and then work together in determining your treatment plan. And one other thing I should say is be careful that you're not just looking for someone that is going to say what you want to hear, because sometimes the truth can be hard. For example, if someone is saying you need a mastectomy for these reasons, but you don't want a mastectomy, it can be difficult to hear that. Make sure you're not just seeking multiple opinions to hear what you want to hear rather than what you need to hear, okay? All right, so when you come to us as surgeons, we will look at your cancer, we'll look at you, and we'll try to work out what is the best package of treatment to get into you to give you the very best chance of a cure. And as I say, also giving you the very best chance of a really good quality of life despite those treatments, because all treatments can have side effects and some downsides. So when we look at the different treatments that are sometimes involved with breast cancer management, there's all sorts of things, and I've listed them here for you, most of the main treatment modalities, so surgery, radiotherapy, chemotherapy, and others. And so it can be confusing knowing, well, you know, do I need chemotherapy, or am I going to have a mastectomy, and so on. And what is very important to remember is that we will tailor a package for you and your breast cancer. So it is not a one-size-fits-all. So just because your neighbor had a lumpectomy and was fine with that doesn't mean that that's necessarily the best option for you. Likewise, just because your aunt had a mastectomy and the cancer came back, that doesn't mean that a mastectomy is necessarily a bad thing. We will tailor the plan to you to give you the best chance of a really good outcome. So in tailoring that treatment package, we look at you and your and specific features associated with you, and we look at specific features associated with the cancer to try and get that match right of putting together the right package of treatment. So when we talk about patient aspects that we are looking at to work out a treatment plan, we look at things like age, we look at things like other medical conditions, perhaps your family history for cancers like breast cancer or ovarian cancer in particular. We look at whether or not you are planning further children or children at all in your life going forward. And all of these things will factor into a treatment plan. One thing I think which is important is when we're talking about age, sometimes I feel that women who are later on in years, perhaps in their 80s or 90s, and we talk about perhaps not providing certain treatments, that woman I find sometimes can feel like, I'm getting older and they don't care about me. It's actually quite the opposite. It is a matter of thinking we don't want to just throw treatments at you which perhaps may not give you much benefit, but do give you all of the toxicity of that treatment in a context. And so in that context, we think we might say, well, this is the reason why perhaps this isn't the best treatment for you. And so, for example, it's very rare that we give people 80 and above chemotherapy because the toxicity is high, the risks are high, and often the benefit, the added chance of giving you a good outcome is just not there. And so in that situation, we will often withhold that sort of treatment in the package. So it really is just a matter of tailoring treatment to your particular situation. Possibly the most important thing when we're talking about patient aspects in a treatment package is what is your input into the decision making, because it is a very consultative process. We don't want to just tell you this is what you have to do and we're going to strap you down and force you through it. Absolutely not. We are going to empower you with information about why certain treatments might be the right option, why other treatments might not be the right option, and explain that to you. And ultimately, it will come down to you take that information on board, and then you ultimately make your decision, and we work with that to try and fit in with your preferences as well. All right. So what about the cancer aspect? So this is where we get into some really nitty gritty. So as I say, it is not a one size fits all for breast cancer management. We want to look specifically at the nature of the cancer that we are dealing with to work out what is the best treatment package to put together for you. So first of all, we look at whether a cancer is what we call pre-invasive, or you might have heard the term DCIS, ductal carcinoma in situ. So pre-invasive or invasive cancer. Now, I think before people have much exposure to breast cancer, when they are thinking about breast cancer, they are thinking about invasive breast cancer. So a lump in the breast that can spread to lymph nodes under the arm or perhaps elsewhere in the body. So that is an invasive cancer. It can invade into lymphatics and spread to lymph nodes. It can invade into blood vessels and spread elsewhere. A pre-invasive cancer is sort of like a cancer that hasn't quite got to that point yet. the breast cells have gone bad, so you've got breast cancer cells there, but they haven't yet developed their full skill set. So they are contained within the breast because they can't invade into lymphatics or blood vessels and spread outside the breast. So pre-invasive cancer versus invasive cancer, sort of like, it's not absolutely a perfect analogy, but sort of like a polyp that you might have removed on a colonoscopy versus an actual bowel cancer. Now, the reason I say it's not a perfect analogy is because you can have a cancerous polyp, but by and large, most polyps are sort of pre-cancerous, if you like. So pre-invasive cancer, it's sort of like a pre-cancerous situation. It is actually cancerous, but not fully developed cancer. So pre-invasive cancer versus invasive cancer. Now, by and large, I'm going to speak mostly about invasive cancers because that is where treatment gets a little bit more complex. Treatment plans get a little bit more complex. So as I say, invasive breast cancers can spread outside the breast, and that is what makes them more dangerous. So when we're looking at an invasive breast cancer, we're trying to work out what is, yes, we can remove the cancer. We could remove the cancer tomorrow, just take you to theatre, pluck the cancer out of the breast and it's gone. But the problem is it may have already spread elsewhere. And even if we do every scan in the world on you, we are not likely to see any sign of cancer elsewhere to know whether it is there or not. Because if it has spread elsewhere outside the breast, it's usually sort of microscopic. So what we want to know is once we've dealt with the cancer in the breast, so say we've done surgery on the breast and maybe even removed some lymph nodes, what is the chance that there could be microscopic disease that had already spread elsewhere that can set you up for a recurrence down the track? And it's what that risk of recurrence is that is what determines how far we are going to go with your treatment package. Because if the risk of recurrence is higher, then we want to give you more treatment to try and bring down that risk. Now, a concept that I use a lot in working out what the risk of recurrence is with a particular breast cancer, with a particular woman's breast cancer, is this idea of the stage and the biology of the tumor. So I sort of think of the risk of recurrence is like the stage times the biology. So what I mean by stage is how advanced the breast cancer is. Is it sort of early on, or is it a little bit more fully grown? So in particular, I'm talking about the size of the breast cancer, and I'm talking about whether or not it has spread to the lymph nodes under the arm. So from that, we can work out the stage of the cancer, early stage or more later stage breast cancer. The second thing that we look at is the biology of the tumor. Is it a less sort of angry looking cancer, or is it a more angry looking cancer? So for example, you can have an earlier stage breast cancer that's a little bit more angry looking. You can have a more advanced stage breast cancer that's a little less angry looking. So we look at those two things to try and work out what might be the risk of this cancer coming back in the future once we've dealt with the cancer that we can see in the breast. So I've mentioned stage, tumor size, and lymph node involvement. What about the biology? How do we work out the biology of a particular breast cancer? Well, we look at a few things. We look at things like its grade. So grade, you might have seen low, moderate, or high grade, or grade 1, 2, or 3. So grade 1 is a low grade or less angry looking cancer. Grade 3 is a high grade or a little bit more angry looking cancer. Most breast cancers are sort of no specific type. You might see on your pathology report, invasive ductal cancer, NST, no specific type. So that's just a standard breast cancer. But sometimes there are different tumor types that subsets of breast cancer, if you like, that might be a little bit less angry or a little bit more angry. So for example, a tubular cancer is unlikely to recur elsewhere, whereas some other cancers might be more likely to recur elsewhere. We look at what we call the receptors, the estrogen receptor, the progesterone receptor, and the HER2 receptor. And I'll talk a little bit more about that later, but I'll talk a little bit more like that later. We look at whether there is any evidence of lymphovascular invasion. So in the tumor, when the pathologist looks at the tumor, say we've removed the tumor from the breast and they've looked at it under the microscope, is there any evidence that it's spreading into lymphatics or blood vessels within the actual, within the tumor lump? And then we look at things like Ki67, which is a genetic marker within the breast cancer cells that we look at to see whether there is sort of, if you like, lots of Ki67 or less. And a higher Ki67 again means a more biologically active tumor. A lower Ki67 means a less biologically active tumor. There are also some other things, some other genetic tests that we can do on breast cancers to try and really nut out is the biology more significant or sort of more indolent, just sitting around? The cancer's biology is the sort that it's just sort of sitting around, not doing a lot, and maybe not spreading elsewhere in the body. All right, so to just recap on that, tailoring a treatment plan to you involves looking at you and the specific factors to you, like your age and your other medical conditions and so on, and it's looking at the cancer aspects as well, how advanced it is or not, and the specific biology of the cancer. Is it more active or less active? And we want to know what is the risk that it could be microscopic spread elsewhere, and using that risk, we will work out a treatment plan. So we're looking at that treatment. We break treatment down into sort of three areas, if you like: local treatment, which is treatment of the breast; regional treatment, which is treatment of the lymph nodes which are under the arm; and systemic treatment, which is treatment of, if you like, your full system, the whole body. So let's look at them in particular. So local, I've actually combined this into local regional treatment. So treatment of the breast and the armpit. So this specifically relates to surgery and or radiotherapy. So surgery to the breast involves either a lumpectomy, or more specifically, we call it a wide local excision because it's taking out the lump plus a little bit extra around it, or a mastectomy. Now, a wide local excision may be a good option if the cancer is on the smaller side, or if we can take the cancer out with a cuff of normal breast tissue around it and still give you a good cosmetic result to the rest of the breast. If, for example, the cancer is bigger or the breast is smaller, and perhaps in removing that cancer, it's going to be difficult to put the breast back together in a good cosmetic way, then we might recommend a mastectomy alternatively. So wide local excision or mastectomy. If you have breast conserving surgery, so if we're keeping the breast, we just take out the cancer and keep the rest. Keep the breast intact, then you will need radiotherapy to the rest of the breast. Now, with regard to the lymph nodes, we will usually just take 2 or 3 or 4 lymph nodes from under the arm, the first ones in line from the breast, to see if there is any cancer spread up to them, and hopefully we can stop there and not go on and take any more lymph nodes out if there is no sign of cancer in those first 3 or 4. Now, when we're talking about local regional therapy, a question I often get is, if I have a mastectomy, can I avoid chemotherapy? These are 2 separate areas. So when we're talking about local regional therapy, we're talking about surgery plus or minus radiotherapy to the breast and the armpit. And that is not going to impact on what recommendations we make for the full body. So when we're looking at systemic treatment, we're talking about, you might have heard of hormonal or endocrine therapy. I'm sure most of you or all of you have heard of chemotherapy. And we've got newer treatments, which we refer to as targeted or immune or biological therapies, which are sort of like really targeted smart bombs heading directly for the cancer cells that can be relevant in some breast cancer types. So that systemic therapy is aimed at treating that risk of microscopic disease that may be elsewhere in the body. So as I mentioned earlier, treating the cancer in the breast is relatively easy because we take the lump out. We've got something that we can see and we can take it out. If we find cancer in the lymph nodes, we can take them out. But this concept of microscopic disease elsewhere in the body is more difficult because usually we don't know if it's there, other than to say there is a higher or a lower risk of it being there based on what we found in the breast. But if we think that there is a moderate or higher chance that there is microscopic disease elsewhere, we will definitely want to give you full body treatment to try and zap those cells before they become a problem in the future. So just to drop back, so we're trying to tailor the treatment plan to you and pick out the treatments that are relevant to giving you the very best chance of a cure, while still thinking about how we can maximize your quality of life by not giving you too much treatment that is going to cause undue side effects. And I think we'll just finish up. I've got a couple of slides left. So I've sort of touched on these already. How do I go back here? So I sort of talked about when we might think about breast conservation versus when we might think about mastectomy. As I mentioned earlier on, if you're having a mastectomy, breast reconstruction is usually an option. Not always, but usually an option. Radiotherapy, I mentioned, we always recommend radiotherapy after breast conservation for like if we keep the breast, then we always recommend radiotherapy after removal of an invasive breast cancer. And sometimes we'll recommend radiotherapy even after a mastectomy as well. When we're looking at the full body treatments, when do we recommend chemotherapy? Well, if the risk of recurrence is a bit on the higher side, and particularly with higher grade tumors, tumors which are not or lesser hormone sensitive, tumors which are HER2 positive. So I mentioned those 3 receptors that we look for on biopsies in the tumor, so the estrogen, the progesterone, and the HER2 receptor. We look at these things. Less hormone sensitive cancers, HER2 positive cancers are cancers that respond better to chemotherapy, whereas more hormone sensitive cancers, ones that like estrogen and progesterone to help them grow, sometimes chemotherapy is less effective in these cancers. And then I also mentioned the stage. So if it's a higher stage cancer, often we just want to get more treatment into you to give us the very best chance of stopping a recurrence in the future. Hormone therapy is relevant in hormone sensitive cancers, and anti-HER2 therapy or this immunotherapy that I mentioned, that's relevant in HER2 positive cancers, which make up about 25% of cancers. So you can see there's quite a bit of complexity here about differentiating between different cancers. And this is the reason why your treatment is often substantially different from someone else you know's treatment, whether it be in the different surgery you have, whether or not you need radiotherapy or not, and whether or not you need chemotherapy or anti-HER2 therapy or hormonal therapy. So there's lots of things that go into working out what is the best treatment. But what is a no-no is just throwing everything at you because we can, because it's all of these treatments can and often do have side effects. So we just don't want to do that. We want to get the treatment right for you. Because ultimately ultimately we are weighing up the benefit of any particular treatment versus the risks of that treatment. And so we want to see a high benefit from a treatment and lesser risk before we recommend it. So if a treatment's got a marginal chance of helping you, but it's got significant risk to you, of course we're not going to recommend that. So that's basically how we think about these things. So I think with that, I will hand over to...
Thank you, Sunny. You're going to hand over to me first. I have so many questions, so you've got to sit tight for the rest of our speakers so that we can come back to you with some more questions. Keep them coming through. And thank you, Sunny. It was like we got to be with you for that very first meeting to start to understand some of the complexities of breast cancer treatment. And as I said, I've got plenty of questions coming your way, so sit tight. But our next speaker is Meg McDonald, who is a breast care nurse. And I know for all of you out there, if you have just been diagnosed, if you have not connected with your breast care nurse, this is one of the most important steps you need to take. And BCNA can help you make that connection if you haven't been able to. But for us to really understand the true benefit of a breast care nurse, that's why we've asked Meg to be here, who works in both private practice and at the Melbourne Breast Endocrine Surgeons. And she's really an integral part of the breast cancer care team. And Sunny talked about the multidisciplinary team approach, and it's essential that wherever you're going for treatment, that you make sure that they do have a multidisciplinary approach. So Meg, we're so looking forward to hearing why every woman, man or person diagnosed with breast cancer should be able to access a breast care nurse in Australia.
That one?
Yeah, the big one.
Hi, everyone. Thanks for having me. Well, you've just come out of the surgeon's room and you come into mine and you go, what the hell just happened? So I sit you down, I get the tissues, I hug you and your loved ones, let you rest, let you take it in, and then we just start dissecting what just happened, piece by piece. So what happens now? The biggest concern for you is, will I be all right? Am I going to die? What do I have to endure? The best advice that I could give you is to bring someone with you to that first appointment when you receive your news. It's a very lonely consultation, trying to take in all that cancer talk that you've never heard before by yourself. So that person can be with you, can touch you on the arm, can center you, and can take some notes that you can refer to later. This is a huge time of disbelief, fear and uncertainty. So my role is very varied. Starts with a hug usually, and then we go on from there. So the main thing I do is try to support the patient and their family. This is done in so many different ways. It can be from getting car parking at the hospital to walking them over for a test to explaining histopathology a bit clearer than they took in from the surgeon. It can be referring you to BCNA for their apps and tools and other breast cancer support things. And it also starts then but doesn't finish. It's an ongoing care. So any time along your cancer journey, you can ring me and I'll answer any questions that you may have. If I'm unable to, I'll find the answer for you. There is plenty of misinformation out there. Okay, Dr. Google is a big dark hole that you can become immersed in and just be full of more fear. Ask for help when you're unsure. Often, though, when you've just come from the surgeon, there might be a few more tests to be done, a further breast imaging, a CT scan or a core biopsy. All of these take courage, and the courage cylinder is hard to fill up at this time. So step by step is what we do. The doctor would have also taken a thorough medical history, and then we have to investigate if you need more blood tests or x-rays concerning comorbidities. Then we just try and plan your cancer care. All of a sudden you have become one of those people that have breast cancer, and there's pink everywhere in your world now. Your treating surgeon will discuss treatment options, and that's what Sunny's just gone through, and which order they will come in. Sometimes you have chemotherapy first, and this is really hard to take up front because it's like, oh, what? That's really bad. I'm going to be bald, I'm going to be this, and what's the cancer doing? Is that still growing while I'm having chemotherapy, or what's happening to me? So all of those things need to be discussed in detail. What are the side effects of the forthcoming treatments? So there's surgery, chemotherapy, immunotherapy, radiotherapy, and there are medications that you may need. So what I try and do is just do each step at a time. If you're going to have surgery, I talk to you in detail about what that surgery entails, what to take to the hospital, take your x-rays, take your nail polish off, take your glasses, take your medications, take your loved one to hold your hand, take a book that you won't read, but take it anyway. I try to encourage that it is best to take each of these steps one at a time. So my role as a breast care nurse, it's to listen and to ascertain what the person before me needs. As soon as the last person goes out, you're a new person that's just been diagnosed. So you may want all the information in the world, or you may want none. It's entirely up to you, and I will focus on what your needs are. The most important part of my job is that the person under my care is given enough information and support to make an informed decision regarding their own treatment. It's about them. This is when they become the most important person, not their partner, not their children. They're important for the next little while. So whatever they feel they need, that's what we do. There's no rush at all. We can take our time. The cancer isn't going berserk as we speak. So time taken to get the information you need is time well spent. You may not gel with the people that your GP has referred you to. That's okay. We'll find you someone else. You may not gel with the breast care nurse. You might think, oh gosh, this is awkward, but just tell someone and we can change your breast care nurse. You will have a lot of appointments with a lot of medical people, and it is hard to get on with everyone. If your questions aren't being answered in a way that you find helpful, then they are of no use to you. So my job is, if you have any qualms about someone, just tell me and we'll advocate on your behalf for a change if need be. Remember, you are the most important person in all this. You have to feel comfortable and be able to communicate freely with those looking after you. Cancer care and treatments can be very expensive, and private health cover rarely covers the cost. It's alarming how much care costs in the private sector. So cancer care is spread across both modalities, public and private, and you can have a choice. You can go between the two. You can have your radiotherapy, private, public, any part of it can be in either. Okay, it's up to you to speak up if you need help with finances. There's lots of help with finances, just ask me. Whilst you're going through cancer surgery and further treatments, there are a myriad of side effects. Cancer affects every aspect of your life from the time you're diagnosed. It affects your relationship, your communication, your appearance, your well-being, your diet. Just the look of you is changed forever. So when you're going through all this, you need someone that can explain, well, this hair loss is because of the drugs that they're using in the chemotherapy, but your hair will come back. The neuropathy that you feel in your hands and feet is a side effect of that chemotherapy. It will go, but it may take a lot of time and care. It's important that you let your multidisciplinary care team aware of anything that is causing you discomfort, because there are ways that we can help. The team may consist of your surgical oncologist, e.g. Sunny. An oncologist is someone who treats cancer. So you've got your surgical, the surgeons, medical oncologists who do the chemotherapy and the tablets, radiation oncologists who look after radiotherapy, psychologists who look after the most important part of you, your head, physiotherapists, and your breast care nurse, to name a few. I say to everyone that walks in my room that's newly diagnosed with breast cancer that there's so many people out there that know everything about nothing, and they're only too happy to tell you their story, or Auntie Peggy from 40 years ago, or Merle up the street, what they went through. And it's usually a miserable tale. It doesn't have to be like that, okay? Breast cancer care has come along in leaps and bounds since I started this 25 years ago. It's good to research for further information, but please go to reliable sources. Credible resources may include your treating team and the breast care nurse. Organisations such as BCNA, My Journey, is a great online tool. It fills in the gaps of information that you may go home and think, what did they say? You can look up on your BCNA stuff and the answers will be there. Cancer Council's terrific, Cancer Australia, Counterpart, Think Pink, and there's also many breast cancer support groups around. For ongoing care whilst you're going through your treatment, they have wonderful group meetings with guest speakers that cover many relevant topics. Some people don't feel comfortable in a support group setting. That's okay, it's not for everyone. However, it is important that you connect with others. Only those that have tread this path know exactly how you feel. The others might be your family, people at the school that have been through what you've been through. You can ring your treating doctors or your breast care nurse anytime if there's anything that you're uncomfortable about. Excuse me. Many years of ongoing trials and research have led us to the groundbreaking treatments that we have available today and will have in the future. Treatment is now tailored to the individual's cancer. The sequencing order of treatments may be different to others. So when you're sitting at the breast clinic and you're talking to Shelley 2 seats up and she says, oh, how are you going on your tamoxifen? Oh, I'm not on that. Why aren't I on that? Just ask and we'll explain why you're not on that. You may not require the same surgery, chemotherapy, radiation or tablets as others. This is because one size doesn't fit all, as Sunny said. If you are concerned, just ask. There's no such thing as a dumb question. I've been doing this for years. You've been doing it for minutes. Your team is there for you. As a breast care nurse, you see people endure what is often the worst period of their lives. They are forever changed for the rest of their lives. Stronger and braver than they ever knew they could be. It is my honour to share a small part in their breast cancer journey, and thank you for letting me look after you. God bless.
Thank you, Faye. And there's absolutely no doubt in my mind that many of you will be online right now going, how do I get access to Faye as my breast care nurse? And I want to, when we come to those, when we come to the questions, really talk to you about the challenges that some people find having access and that fear of not wanting to be a burden to the nurse that so many people report back to us. But now it is a great pleasure to introduce you to someone who has stepped in your shoes and who has taken the path ahead of you. And it's always a joy to hear the experiences of the members in our network. And tonight is absolutely no exception. So it's with great pleasure that I introduce Faye, who is a self-employed mother of 3 daughters. So I think we need to say congratulations on that in itself. You talk about the importance of being self-sufficient and really taking the power back in your breast cancer experience. So Faye, I really would love to hear what you've learned along this way and how you can kind of impart and support those people who are just behind you in their journey.
I'll try my best. Thank you, KP, and thank you to BCNA for inviting me to be part of tonight's webcast. The BCNA webcasts were a really valuable resource to me during my breast cancer journey, and I'm thrilled to be able to share my experience tonight so that it can help others. My journey started in September 2019 when I discovered a lump on my right breast after a shower one day. I was very fortunate that I have a great relationship with my GP who knows me well, knows my need for speed, knows I need answers quickly. So after she examined me, she quickly booked me in for a mammogram the next day. My GP also does surgical assist with a breast surgeon. So after their surgical session that day, they reviewed my mammogram and quickly noticed some abnormalities. So by the time I got to my follow-up appointment with my GP, I was already booked in to see a breast surgeon. The next week or so after that was a rather robotic experience for me, bouncing from one medical appointment to another, having scans, MRIs, biopsies, and among a few other things. This, however, was eased a lot because this was all facilitated by my breast surgeon's office. So I just really got the appointments in the diary and just went from one to the next. During these early weeks, I also caught up with a trusted friend whose close friend had recently been treated for breast cancer, and she gave me an insight into her care team and some of the tips to care for myself. I've always been someone to make decisions based on intuition and relationships. So coupled with a bit of Dr. Googling, I decided that I didn't want to see the oncologist that my breast surgeon had initially referred me to. And so I didn't hesitate to ask for another referral. Once I met my oncologist and had all the treatment plan explained to me, my first priority was to go back to my volunteer job at St Kilda Mums, just so I could get back some sense of normality. And I was determined to be Faye during this process. I didn't want to be identified just as a breast cancer patient for the next 6 to 12 months. The biggest communication challenge for me was sharing my diagnosis with my mum and our children. We've always been very open with our children, so I found it quite hard initially when I found out, but I didn't have the full picture because we really wanted to be able to answer as many questions as we could, just so that they felt secure and comfortable knowing what was coming up ahead. So the children could sense that there was something going on, as my husband was at home a lot, taking me to appointments, and myself taking after-hour calls from my doctors. So one of the most helpful tools for communicating with our children was some books given to me by my breast care nurse. One, which I think was written by the Anti-Cancer Council, gave really good, simple language and messages to share with the children. And another one was an illustrated story, which was really helpful to my youngest daughter, who was 8 at the time, so that she could read in her own time and then for her to ask questions of me of what was going on. I was also very worried telling my mum, as my dad had only recently passed away from cancer and 3 of my mum's siblings had lost their lives to cancer. In some ways, managing my mum's reaction to my diagnosis was more stressful than the diagnosis itself. And so what I found helpful was taking my mum along to my medical appointments so she could ask questions and she could see how much chemotherapy treatments had moved since her siblings were being treated. In terms of communicating with extended family and friends, there's a host of communication tools out there. You've probably heard of WhatsApp and Gather My Crew. But what I personally found helpful was a very long, detailed email that I drafted up, and this included everything from my specific diagnosis, who was in my treatment team, what my treatment plan involved, where and when my treatment was taking place, how our kids were handling the situation, how to contact me, what help I wanted, and also what I definitely did not want. I think the time that I put into drafting this email meant that both my husband and I weren't constantly fielding the same questions over and over. I was lucky to have a lot of family support, and being an introvert, I didn't want to be locked into rosters for school pickups, food trains and that kind of thing. So I didn't need to use a lot of the sophisticated communication tools. In terms of going into the treatment, I'm a bit of a control freak. So once the treatment plan was explained to me, I found it helpful to break it into 3 distinct phases, just so that I wasn't overwhelmed by the next 6 to 12 months. Initially, I parked the whole surgery and reconstruction phase, and I focused solely on what I call the red devil part of my chemotherapy. And I reminded that although this was going to be tough, there were really only 4 of these. And so when things got tough, my family were able just to remind me, well, there's only 1 or 2 to go, instead of saying, oh, got another 6 months of this. I also consulted an integrative oncology naturopath whom a friend referred me to. And if you're interested in this, I think there's a whole webcast dedicated to this on the BCNA site. But I found this to be really beneficial in managing side effects and helping my treatment along. And of course, if you do choose to go down this path, don't forget to share what you're doing with your oncologist. From there, I focused on the 12 weekly treatments of Taxol. And although I was advised that Taxol was a walk in the park compared to the Red Devil, I personally found this part of the treatment really challenging. My treatment day was Monday, and I just seemed to feel that rolled around all too quickly, and I began to resent starting my week with chemo every Monday. I was also during this stage that my hair thinned. I put on a lot of weight, and I was retaining a lot of fluid, and I also developed peripheral neuropathy. The third part of my treatment was surgery. Initially, my breast surgeon had indicated a lumpectomy might be possible once my tumour had been shrunk. But as my treatment went on and I started discussing surgical options with my surgeon, I was a little bit worried that because of the size of my breast, that it might not produce the clear produce clear margins. And I'd heard in some cases that people had to go back for further surgery, and I just didn't want to have to do that. And I don't know why, but I was very reluctant to do radiation therapy. So I decided on what some people might consider quite radical, and I decided to have a double mastectomy and an immediate reconstruction. As Sunny said before, the surgeon will advise what's best for your situation, and my breast surgeon did advise that a double mastectomy wasn't necessary, but I had looked into my options and I was sort of quite comfortable with my reasons, and I did proceed with that. I chose my plastic surgeon based on recommendations from 2 other women I know, and I was fortunate that both of my doctors operate from the same hospital and they were familiar with working with each other. So I was able to go the immediate reconstruction path. And then I later found out that my plastic surgeon was a contact of my trusted GP, so that gave me a further level of confirmation that I was in good hands. I had never had any surgery prior to the mastectomy other than the lymph node biopsy, so I was pretty nervous. This surgery was happening just as COVID was declared a global pandemic, so I wasn't allowed any visitors, and I found it very tough giving into every inhibition, but it was necessary because I wasn't even capable of, moving a pillow to get myself more comfortable in bed. I also discovered that I had to pretty quickly give up my mantra of just get on with it and doing yourself, because I do things yourself, because I wasn't even able to pull my tray table a couple of inches so I could reach into my breakfast. My advice is when you're in hospital, it is difficult, but if you take the advice of your breast care nurse, do your physio exercises, use the inspiratory exercises, take regular walks around the hospital, you'll die because you will be half stooped and you look terrible in your surgical gown and your compression socks, but it really does assist on the road to recovery. My treatment is still ongoing today with hormone therapy, so because I had an ER positive cancer, so I'm still taking, I'll still be on that tablet for another few years, but the main side effect for me is just joint stiffness, but I found that was quite easy to manage with a supplement and regular movement. In fact, I found exercise really helpful through the whole chemotherapy process. The solitude in the fresh air every day helped me manage the nausea and was really helpful in providing a distraction from chemo. I was lucky enough to be part of an exercise study at the Baker Institute, so I worked with an exercise physiologist that had a lot of experience with working with breast cancer patients. So I did baseline testing and then had a program written for me to work through in the different parts of my treatment cycle. So I was able to continue training no matter how terrible I felt, and I was also able to meet other women that were more advanced in their treatment, and we formed a really great little support network for each other. But don't get me wrong, there were certainly days that I didn't feel like exercising, but once I did, the endorphin rush really did make me feel better. And looking back, I also think that the exercise and weight training that I did put me in good stead for the surgery. Another thing that I did once I knew my treatment pathways, I checked in with my GP and my at my psychologist to unpack what was happening. Looking back, I think this is one of the most positive and helpful things I did, as I could clarify things that my specialist had discussed with my GP, and just talking to my psychologist was really helpful in keeping things in perspective and not getting bogged down where I was at a specific point in treatment. It's great to have all the support of friends, and whilst on the most part they're very well-meaning, I think it's important to know yourself and the types of people you need around you when your energy is depleted. Of course, this is not a time that you have a lot to give others, and I would just say it's okay to limit your time with people who may be a little bit needy and a little bit exhausting. With regards to practical support, I found I didn't like having practical support locked in, and I was lucky to have friends that were willing just to be on standby and text message for last-minute help with picking up kids when I was tired or just not feeling up to it. One of the things I really appreciated was just little things like people dropping off home-baked goods for kids' lunch boxes. It might not be something that you think ahead, when you're looking at setting up support, but my kids really appreciate that as well. Something that I wish I had have known going into treatment was how bloody long it takes to fit the cold cap and how much time you need to wear the cap pre and post infusion. I committed to using the cold cap because my 8-year-old daughter was pretty horrified with the thought of having a bald mum. And so I was just say to anyone that's considering using the cold cap, it does add a significant amount of time to treatment each week, and in some cases it takes longer than the infusion itself. The other thing that I wish I had realised was how painful it is with them, with the oncology nurses looking for veins as the time progressed. And I wish I had just opted for a port at the beginning of my treatment. It saves a lot of time and, a lot less pain. So a few final messages with respect to my experience. I would just say, know yourself, make decisions that sit well with you. Don't look at what others are doing because, as Sunny said, everyone's experience is different. Everyone's cancer is different. And do what you want to do, not what other people want you to do. And trust your judgment. If you need to change doctors, do that. If you want to do a lot of Googling, even though there's a bit of a minefield out there, go ahead and do it. And finally, I would just say exercise as much as you can and as regularly as you can.
Thank you, Faye. Such a fantastic insight and so many practical tips. I want to start the question time with you.
Sure.
And so someone did send through a question around your hair, because
Okay.
I think people heard September 2019 and went, hang on. So you went through cold caps?
Yes, I did use the cold cap. So my hair never actually fully fell out. I never had any patches as such, but it did thin out a lot, and obviously my eyebrows and eyelashes fell out as well. But in using the cold cap, the oncology nurses explained to me that your hair does actually start growing during the treatment. So I had lots of spiky bits in the second part of treatment, but it's probably grown back thicker than it did before, and it's probably even slightly longer than when I started. So worth it if you can use the time commitment, or if you're prepared for the time commitment, I should say. And
endure it, from what I hear. And I think it is important to say around the cold caps that it works for some people and it doesn't for others. And so it is something, Meg, that we need to make sure people really are informed about when they make those decisions for themselves.
Yeah, I've found in my experience that cold caps have come and gone over the last 25 years. With limited success. So I try to educate my peeps that for sure, give it a go. It does add on time. It isn't very comfortable. And if your hair starts falling out, that diminishes your hope. So sometimes that's more distressing because they've put a lot of hope into that treatment. So be prepared for it maybe not working, but for all intents and purposes, give it a go, see how you go.
I want to stay with you, Meg, for a second around the, when Faye spoke about the importance of the psychologist. What we know from those people, and I feel like BCNA is the organisation that's 170,000 women and men and people have gone before you, and we're taking all of their advice and putting it into our resources. And what I have seen over the last 15 years is how people explain their experiences, that they'd go through treatment and there'd be all this support there for them. They'd be able to see you whenever they were in clinic and, they felt like someone was holding their hand. Then they finish treatment and the cliff falls off. And what we're trying to do now with optimal care pathways is to say to people, we really need you to deal with the emotional stuff right up front and start seeing the other end of treatment at the really early days. Can you talk about the importance of getting that emotional well-being sorted early on for people?
It is a minefield because a lot of people will go to you, no, I'm fine. And you go, well, how are you fine? What are you doing to help you be fine? Well, I'm exercising, or I ring my mum, or I ring my sister or a friend. But how's your head? Oh, yeah, I'm fine. And if they say fine 3 times, I know they're not fine. So then you go, well, what if you get a mental health care plan from your GP, or we've got this person you can ring us. But I do find the end of treatment is when they go, because they've gone from having everyone worry about them, especially if they've had radiotherapy. They've seen someone going, oh, g'day, Jill, how are you today? How are the kids? And then they're at home by themselves at the end. There's not another visit for a year or 6 months, and they go, oh, who's looking after me now? And it's not because they want attention, they just want reassurance. So that's when we tend to ring them a little bit more, or say, come in for a debrief of what's happened, because they've finally got off that little escalator and they don't quite know where they are, where their place in the world is now.
I spoke a little bit about after you spoke. Overwhelmingly, people want to spend more time with their breast care nurse than less. But getting that balance and making sure that there is the actual workforce in place to help people at those critical moments in time. If someone's online tonight and they don't feel like they're getting that support from their breast care nurse, what are some things that they can do to reach out to get that support?
From their breast care nurse?
Yeah.
The thing about breast care nurses are they're not that common. That's what I found. Like, I work with great surgeons that realise that we're the most important person in the team. I need to check. But because when you're with the breast care nurse, we ask probing questions, or we have to look after the whole family, not just that centred approach. So you might only have 20 minutes with that woman or man, and it's like, oh, I've only touched on 2 things, and their head's full of what they've just been told by the surgeon. So I always just reiterate to all my people that I look after, please ring me anytime, because often a phone call is good, and I can be on the phone for an hour to one person and they just feel so much better because someone's heard what they're talking about. But it is a paid job, so the time limits are on you, because it's not unending time that you can spend with everyone because of the sheer weight of numbers as well. So, but as I said in my thing, there's no such thing as a dumb question.
And I do want to encourage people who might be online who haven't got a breast care nurse or have not been in contact with a breast care nurse to call our helpline on 1800 500 258, and the team can help you to navigate to find your breast care nurse. And it is complex because there is all different scenarios with breast care nurses right across the country. Of course, we have the magnificent McGrath Foundation supporting nurses, but there are more nurses than just the McGrath Foundation as well. And I think sometimes people aren't aware of that. So please call our helpline and we'll help you to navigate there. Sunny, I've got quite a few questions for you. So you ready? You're sitting tight. My first one, which has come up a few times, is about requesting genetic testing for families. And I know that when you speak to people newly diagnosed, their immediate reaction is often, there's no one else in my family. So there's kind of this myth busting that we have to deal with around genetic testing. But what are the indicators that would make you say, I think now it's important for the family to be tested as well?
Okay, so anyone who has a cancer diagnosis, breast cancer diagnosis, we're going to invariably, as part of the process, I'm always thinking about, well, what is the cause of this breast cancer? Is it just bad luck because breast cancer is common, or is there something that has predisposed this particular woman to getting a breast cancer? So the flags for me are a strong family history. So, for example, if there's 2 or 3 first or second degree relatives with breast cancer of that woman, then that's potentially a high risk family pedigree. Other trigger factors are if there is young diagnoses in the family, so women with breast cancer under 40 in the family, ovarian cancer in the family, because the same genes that can predispose to breast cancer can also predispose to ovarian cancer. So ovarian cancer in the family, particularly diagnosed younger, for example, under 50. If there have been multiple cancers, for example, a woman in the family has had double breast cancer, so cancer on both sides. Certain types of breast cancer in the family, and in particular triple receptor negative. So that's estrogen, progesterone, and HER2 receptor negative breast cancers. And then there are some rarer things like, for example, certain sarcomas, a history of sarcoma in the family, which are soft tissue or soft tissue tumors, soft tissue sarcomas, Ashkenazi Jewish heritage. So, for example, if a woman has breast cancer and she comes from an Ashkenazi Jewish background, which essentially is a European Jewish background, Eastern European Jewish background, these are all flags that you say, well, these people or this family has a higher risk of having a bad gene in it. So if we identify that the family is a high risk family, or it is a high risk family pedigree, then we would like to test that family. So what that means is selecting one of the affected individuals in that family. So there's no point testing someone who hasn't had breast cancer, because there might be a bad gene in the family and it just hasn't passed to that person. So we would like to test one of the women or men, and actually a male breast cancer is also another flag for a genetic predisposition to breast cancer, because male breast cancer is rare. So when it happens, you wonder, is there a bad gene in this family that's predisposed this man to breast cancer? So we would pick someone in that family who has had breast cancer, and ideally we would pick the person who's got the sort of riskiest looking cancer, for example, if they were diagnosed young, if they had cancer on both sides, if they've had breast and ovarian cancer, if it's a male, and we would test that person. Now, if that person doesn't have a bad gene, then either there is no bad gene and this is just a coincidence that there's a bit of a cluster of cancer in that family, or there is a bad gene, but it's something that we haven't discovered yet, so we can't sort of look for it. So there's a positive result, so a BRCA1 or BRCA2 mutation, for example, and there is an indeterminate result, or a non-informative result. We call it in that we don't say there's no gene, we just say there's no gene that we can identify. Now, if we do find a bad gene, then you can test anyone else in the family for that gene to see if they have it. And if they have it, we know they're at elevated risk of breast cancer or ovarian cancer or some other cancers. If they don't have it, then we know why there is cancer in this family, but that particular person doesn't have that genetic predisposition. So they're sort of in the clear, so to speak.
And I would encourage people, we've got a podcast around genetics and breast cancer, and it is good to make sure that if it is something that you're worried about, to kind of understand it, because I think people get frustrated with the system when they want to be tested, but the system's kind of saying, well, actually, we don't think there's a risk there, and really not understanding the evidence and the reason behind it.
Yeah, well, I had a discussion this afternoon actually with a patient on the phone who has been diagnosed at a reasonably young age, and she has one relative who's had prostate cancer, and prostate can also cluster with breast cancer in certain genetic syndromes. And I had this exact discussion that in reality, the chance of there being a bad gene in this family is low, but we can involve a genetics team, or and if we involve a genetics team and they identify that there is a reasonable chance of finding a bad gene in this family, so for example, more than about a 10% chance of finding a bad gene in this family, then there is Medicare-funded testing available. If, however, we assess that the chance of finding a bad gene in this family is less than that, so often it's 1% or less, then there is no indication under for that testing to be funded, but the patient can self-fund that. It's around about $500. So, not cheap, but not ridiculous. So they can self-fund those tests.
Let's stick with that, self-funding.
Mm-hmm.
A very big advocacy area for BCNA is around genomic testing. It's actually come through on a number of questions tonight. Can you, first of all, explain to people briefly what genomic testing is, and the fact that in Australia still today people are needing to self-fund, and why people might make a decision to have a...
Okay, so there's a bit of confusion sometimes with genetic testing. Some people are thinking genetic testing being looking for a BRCA1 or BRCA2 mutation. So that's looking for why you might have developed breast cancer. Have you got a BRCA1 gene that predisposed you to breast cancer? Genomic assay is a different type of genetic testing. And what it is doing is it's taking a piece of your breast cancer and it's looking at certain genes or the genetics within that breast cancer to try and work out that question that I was talking about earlier. Is this a higher risk cancer or higher biology cancer, biologically more active cancer that might have a higher chance of having spread elsewhere, and therefore maybe there's more more reason to think about chemotherapy in this context, in this treatment package, or is this cancer a sort of less biologically active cancer? So we take a piece of the cancer, it gets sent off to the lab. And they look at up to, one of the tests has 21 genes that they look at, and they try to work out, and it generates a recurrence score. And essentially what that score is looking at is looking at that one particular test that I was just thinking about, which is a 21 gene assay. It generates a score between 0 and 100. If the score is above 30, then that's a cancer that is of higher biologic potential, so higher risk of it having spread elsewhere in the body, even if we can't see it elsewhere. And these are the situations where we might be more inclined to recommend chemotherapy. So for example, the way I think of these tests is, if I was chatting to you after we've done surgery on you and I've said, look, this is the results from the surgery, and you need to have, for example, radiotherapy to the rest of the breast, hormonal therapy, and maybe there's a little bit of added benefit, added chance of cure if we add in chemotherapy to your mix. Now, as Faye said, it's no walk in the park going through chemotherapy. And people are often horrified by the idea that, oh gosh, I just don't want to have chemotherapy. Well, no one wants to have chemotherapy, but on the other hand, if it's a lifesaver, if added into your package of treatment, it gets you over the line to cure, then of course you want to have chemotherapy. So if I said, oh look, there's about a 4% chance that this could actually impact positively, like a 4% chance that this could add to a cure in you. What that really means is that if there was 100 women with that exact breast cancer, and we gave all 100 chemotherapy, for 4 of them, the chemotherapy is a game changer. It gets them across the line to cure when they otherwise weren't going to be cured. For the other 96, it's made no difference whatsoever. So they were either going to be cured even without the chemotherapy, or they are still destined for a relapse even with the chemotherapy. So then the lady says to me, okay, well, I don't want to have chemotherapy if it's only a 4 in 100 chance of making a difference. But the problem is the stakes are high. So that 4 in 100 chance is a life-saving decision. So if there was a test that could select out between those 100 women, the 100 Fays, which are the 4 that get the benefit of chemotherapy, then you'd want that test. Because if you could get that test and say, yep, you're one of the 4, then you're going to have the chemotherapy, and the other 96 are not going to have the chemotherapy. These genetic assays, these genomic assays, are trying to look deep into your specific cancer, not the other 100, but yours, to say, are you in the 4 or are you in the 96? Now, they're not perfect, and they're very expensive. They range between $2,500 to $5,000, really, and they're not covered by Medicare. They're not covered by health funds. They're really not covered by anything. There have been various pushes to try and get these covered. And there are even some indications that they may be cost savers because if a test turns someone from having chemotherapy to not having chemotherapy, well, you've saved all of the money that Medicare would have spent on delivering that chemotherapy. So there are some cost savings to be had, but at this stage in Australia, they are not covered by anything, so they have to self-fund. Now, they're not relevant to everybody with breast cancer. They are relevant to a certain selection of people with breast cancer, with a certain group of people, really. People with hormone-sensitive breast cancers with limited or no lymph node involvement, who are a little bit borderline between should we have chemotherapy or should we not have chemotherapy.
People can find out more information on who it's relevant for through the My Journey app, and I think it is important to be informed before you start making some of those high financial decisions that you're needing to make. And Faye, finances come through heavily on the questions. It is BCNA's priority for our policy and advocacy to try and reduce the cost of breast cancer for all Australians. What are some of the financial things that you put in place to make sure that, if you can remember them? Because I think, like, did you keep a record of all of your costs? Were you getting people to help you with finances? We
were able to manage the finances ourselves, but I'm very detailed with filing and stuff like that. So I created a whole file of, I just called it my breast cancer file, and I was keeping a track of expenses, but in the end I just had to stop because it was just, it was quite depressing looking at how much it was adding up. But
did you feel like you were at least in control of understanding what the finances were, or did you have that experience of that kind of financial shock that people talk about, and that accumulation of every time you go to your letterbox, you've got another bill to pay that you had no idea about?
Well, I did have that, but on the other side, like sometimes I didn't know what to expect. And for example, when I went to have each chemotherapy treatment, I would be signing all these forms, but I actually never paid anything. So I didn't know whether it was Medicare covered or whether it was covered by my private funds. So in some ways I was pleasantly surprised, but obviously, the surgery was very expensive. Obviously I got a quote before I went into it, but it's quite frightening how much all of that costs, for sure.
Meg, you won't be surprised that online everyone's like, what can I say from a financial perspective? And I know, there are different opportunities for people in both public and private, so it is quite a complex kind of navigational piece. But what would be some of your key kind of financial tips to give people?
I think you need to be upfront with your treating team, because when you're first diagnosed, there's so much fear and uncertainty, and you just go along with what they're saying to you. And along with the genomic assays that are, so expensive, if one of your doctors is saying, well, we can work it out properly, or this is a really good test and it's only $5,000, well, for peace of mind, people might be paying that for no reason. Like, there's so many bits and bobs that are so expensive. I think a good thing to do is always ask the costs up front. Ask if there's a different way of going about certain treatments. And I work with private specialists, but we will always talk in my little room with my patients. There is this way you can go or that way you can go. And people tend to go, well, my doctor said this, I have to do that. Well, not necessarily so. There's talk to other people that have been down this road. They're the ones that know more than anyone. And the costs do add up. Save the costs and go for a holiday at the end is what I say. Like, really, because you're well, but you'll be well either way.
And I think the early decisions people make in their treatment can impact them financially long term. And no one really understands it until they're looking back. And, the role that people like BCNA can play is to help you ask the right questions at the right time to make sure that you're not making financial decisions that you don't need to make. And Sunny, you talked about how we're pretty lucky in Australia. We've got 2 great systems that people can choose. But I don't think anyone really understands how little their private health insurance will kick in until it's too late, often, for people.
Yeah, it's really complex. I mean, when sometimes we get emails to the practice saying, can you provide a quote for this surgery? And it's nigh on impossible to provide that quote because you don't know the details of that patient's requirements, and there may be anaesthetist involved, assistants that may charge an out-of-pocket fee. By and large, the out-of-pocket fees for private patients are medical fees. So surgeons charging beyond what the health fund provides. So that's basically the out-of-pocket costs. There are a few things like the genomic assays that are expensive, but by and large, it's medical fees. So as Meg said, you have to have a frank discussion with us. We are very clear about what we charge. I think it is something that it is a very uncomfortable area for me because I want to provide really good care. In my opinion, I think we charge very moderately, but we do charge an out-of-pocket. I hate this area, but I started off charging no out-of-pocket, and it's really just not sustainable in the private sector. So we charge a moderate out-of-pocket. We try to inform people fully, but there are still things that are out of my control. So if one of the big costs is breast reconstruction, plastic surgical costs can be quite large. Yeah. And so what I always say to all of my patients, I had a patient who was uninsured who I operated on this week. I made it so she self-funded her operation. I actually don't like operating on uninsured patients because I feel that pressure that this is costing this woman a lot. Mm-hmm. We make it, Meg and I, and I can't speak for the other surgeons in my practice, but we all charge moderately, and not in my opinion excessively. We make it very clear what the costs are up front. And we also in my practice, there's 5 surgeons. We all work in the public sector as well. And any of us can transfer care for any part, as Meg has said, for any part of your breast cancer management into the public, whether it's surgery, whether it's radiotherapy. There's a common misconception that breast reconstruction can't be done in the public. It can. So, there are ways around it. But then you get but I want you as my surgeon, and I won't be guaranteed that in the public. This is a reality of the public system, is sometimes you don't get that continuity of care that you want. Sometimes you can't pick your specialist. But what I tell all of my patients is, even if it's not me, in my hospital, it will be a breast surgeon that is doing your operation, and there's a good chance it's going to be me. You are going to be looked after well. Usually it's not an issue with the actual breast cancer management with us, because, as I say, we don't charge excessively. But I always point out that these things do add up. Your biopsy, your surgical costs, maybe the anaesthetist charges a couple of $100, and it does all add up. And you just have to try. We have to try and be clear and not duplicitous with patients. And I can tell you, from my point of view, I don't want to be duplicitous. I don't want unhappy patients. I want to look after my patients well, hopefully my colleagues are all the same as well. I mean, it is a problem though.
Sadly, Sonny, not all your colleagues are the same. What I can tell people is that, true that, you really need to start those conversations early. And that's about going back to that real essence of having a team around you that you trust. And trust means that people can have a conversation that's open and frank. And I really want to encourage people to be having those open and frank conversations around finances, because all too often at BCNA we're hearing about the issues when people wish they'd done something about it early. So I know we've probably spent more time on it than people would expect, but it really is a life-changing moment for people, and finances are a really important conversation to have up front.
And I'll just circle back on that point. You have got time. If at the end of the day you feel, oh, this is a big problem, this is going to get beyond me, you have got time to seek alternate opinions, whether it be in the public or with an alternate breast surgeon. You have got time. So you don't need to panic. There is this idea that, oh my gosh, I just need to get this done tomorrow. You don't need to. You have got time to make a considered choice.
Absolutely. And that has to happen right at that very point of the diagnosis, which I want to go back to, Faye, you talked about your GP. I think there's a couple of critical things that people need to do in those early moments of a diagnosis, and securing the right GP. It sounds like you had a great experience with that.
Yeah, I mean, I've known my GP for a long while, and I have mental health challenges that she's helped me through and referred me to various people along the way. And so that's why I have a very high level of trust with her. And because she knows, as I said before, that I am impatient, and you know, everyone tonight has said you don't have to hurry in things, but just for my own mental well-being, I can't sit on things that the more I sit and stew, it just, you know, works me up more. And so she knows that about me. And I think that's why she, you know, because some people might say, well, don't you think that's a bit weird that your GP went and consulted a breast surgeon, you know, before she even discussed your results in the mammogram? But, you know, I trust her, and she knows me, and she would, you know, she would know that I would want those answers quickly. So, yeah, I definitely think it's really helpful if you've got a GP that you can trust, because they're the ones that can really decipher a lot of the information that the specialists are giving you.
Yeah, and I think they're going to see you through post your treatment years as well. There is a question directly for you, Faye, around the books that you read. If you can't remember them, can you remember the names of the books?
I can't remember. I just know that the first one was an anti-cancer council one that I got, and the other one was just a storybook, I'm pretty sure.
The comic book?
That wasn't the comic book one. It was more like an illustrated picture book. So, you know.
Yeah.
Like
so I can tell you that we have a full list of books on the, through the My Journey app that people can go and look at, because there's a big wide ranging of telling kids and how they react to that. I've got time for a couple more questions. I'm running over time. Sorry, Sunny, but there's too many here. One question around the multidisciplinary team meeting. And so you said that people will see you first, but there is the emergence of neoadjuvant treatment. How do we make sure that that is discussed early on for a patient to really understand what's going to be their best treatment options for them?
Look, it's a really good question. And this is, at the end of the day, it does come down to that primary specialist, which is the surgeon. So if there are fairly clear indications for neoadjuvant chemotherapy, so chemotherapy before surgery. And anyone who is well-informed should know those indications. And so as the surgeon, if I feel that a patient is a good candidate for neoadjuvant chemotherapy, and I should know that, then I will speak to a medical oncologist. So there's multidisciplinary meetings. So we have one on Tuesdays and Thursday mornings, for example, where we discuss all of our cancer patients. And then there is multidisciplinary care where, for example, I rang my radiation or one of the radiation oncologists that I work with on the way here to discuss a patient's pathology which has just come back before I speak to that patient. So I will get advice from my colleagues in other disciplines, and that's multidisciplinary care too. So if I am thinking about referring someone to a medical oncologist for their primary treatment being chemotherapy, I'll usually send that oncologist a text, or I'll So, can you give me a call when you're free, and we'll chat about it so that we're all on the same page.
Should a patient have access to the discussions that happen at a multidisciplinary team meeting?
They do have access to it. I tell them. So, if you're saying, should they be at the meeting? Well, they can't be, because there's confidential information about other patients being discussed. They hear it. Basically their treatment plan is going to be what is discussed at that meeting.
Yeah. So if you haven't had an update from your key clinician around the MDT, it's an excellent question to ask them about what was discussed about me at the MDT Meg.
Yeah.
I usually go through my list because I organise those meetings, and I've got my list of patients, and I would ring them on the day. We talked about you today, and this is what the outcome was. And next time you see this, or this, they'll give you a referral for this, or this. So it's the patient's right to know what has been said about them, and that's what I do, because they're informed that that's going to happen. It's no use informing them without telling them what happened in it.
Well, we could go on all night, and I need you to pass me back my so I can move my way through the next lot of slides. But I do want to we've talked a lot tonight about resources and places to go, and I think it is important to say that it can be overwhelming. We absolutely know at that point of diagnosis, you're given a lot of information, and people describe it to us as they walk into their bedroom and put all the pieces of paper in a corner, and they don't necessarily go back to it, and then they wish they had. So what we did was we took our My Journey kit, a hard resource, and made it into an app so we could curate the information to you at the right time for you. So it means you don't have to read up on all the information that's not relevant for your treatment. So I would really encourage, if you haven't signed on to the My Journey app, to do so, and make sure that you then link in with all the different articles and resources. This is what the My Journey app looks like. It's pretty simple and user-friendly. I think Steve Jobs would be pretty proud of the BCNA team about how simple we've made it. And also you can track your symptoms and keep diary notes in preparation for your meetings with your health professional. And they can be so helpful to understand where you are through your treatment, on what days are great days and what days you might need to get a little more support in hand. And we keep updating that resource every time there's a new treatment announced. Anytime there's a change to information, we'll make sure that app is updated really quickly. There are loads of information and resources out there. Here's just two examples from the Cancer Council. But I do want to pick up on a couple of questions we weren't able to get to tonight around the emotional wellbeing. BCNA last year launched a podcast called Upfront about breast cancer with Dr. Charlotte Topman, who's a clinical psychologist and psycho-oncologist, but also is a woman who has experienced breast cancer. And she takes you through an incredible 10-part series where she looks at what breast cancer diagnosis was like for her, but then adds the element of her knowledge and understanding from a psycho-oncologist perspective. So I would really encourage you to listen to that podcast as well. We have this week launched a number of new podcasts for people who identify as LGBTIQ plus community. We know that coming out is very difficult for people who identify in this community, and we completed a research project that has really helped us to build the research and knowledge that we have to make sure that we can better support you and be a network that welcomes you and make sure that you feel like you've got someone walking with you. So I'd encourage you, if you do identify as LGBTIQ+, to look at those resources, and we will continue to update them whenever we can. We're thrilled that we will be doing another Ask the Expert on lymphedema, and March is lymphedema month, so there's been lots of information about lymphedema, but we're doing a specific Ask the Expert on that. And we will be heading back out onto the road for the first time since COVID-19 hit. And we are heading to Ballarat first, where we will take Dr. Charlotte Topman, but as well Belinda Yeo will be with us to talk about the very latest in treatment and care. There is a lot going on at BCNA. If you need to keep up to date, the best way to do it is through our social channels and, of course, receiving our beacon quarterly. I want to thank Suzanne, who has helped us to bring Tonight to us. They've been with us since 2005, and our long-term partnership means so much to all of us. To Faye, Meg and Sunny, thank you for giving up your time. 3 incredible speakers. There's been a lot of content tonight, and I know that the comments will be racing through on the website. So thank you all. I'm sorry we couldn't get to all of your questions, but please stay connected to BCNA and look at all the other resources where we hope we can answer as many questions as we can. Thanks very much.